All right, we're going to get started. And last week, I gave the lecture on small cell lung cancer, and I'm supposed to be the speaker today, but I took the place of Dr. Nichols, who is going to talk today about radiation oncology. So she got her undergraduate degree at Duke University. Subsequently, she went to the University of Maryland Medical Center in Baltimore, got her MD degree. She did an internship, and her specialty is radiation oncology. And now she's an assistant professor at the University of Maryland, the Marlene and Stuart Greenbaum Cancer Center. Her title, Introduction to Radiation Oncology.
Thank you all for having me today, and thank you, Dr. Moody, for asking me to speak. So today I was just going to go over some of the basics regarding radiation oncology for everyone today. I have no disclosures. And the outline for our talk today is to initially talk about some of the goals of cancer therapy, some of the goals of radiation therapy, and then talk a little bit about the basics of radiation oncology, so radiation physics, radiation biology, and then clinical radiation therapy as well, and how this really impacts the patients that we care for. And then at the end, I'll spend a couple of minutes talking about some of the future research opportunities in radiation oncology. And I'd also like to thank Dr. Camphausen for some of these slides as well. So in terms of some of the principles of cancer therapy, we've listed 5 things here that I'll spend a minute or two touching on. So basically, in terms of cancer therapy, we obviously want to cure patients of their cancer, but we want to do that in a way where we're meeting some of these goals here. So first and foremost, kind of minimizing therapy, so only giving patients the therapy that they need to actually treat and potentially cure their cancer. And along with that, we want to make sure that we're minimizing any toxicities the patients may experience, minimizing the amount of time that they're actually in the doctor's office or in the hospital, and also being mindful of the cost of cancer care. And I think all of us have seen in the news many articles talking about the cost of cancer care in our health society. We also want to minimize the negative impact on the patient's quality of life. So again, this gets back to the toxicity that the patients experience from their therapy. Maximizing their function. So again, back a long time ago when patients had sarcomas of the upper extremity, for example, they all had to have their arm removed. But now in today's world, based on some of the studies that were actually done here at the NIH, we can actually find that we can do a limb-sparing therapy, so maintaining patients' function, and then also trying to maintain a patient's cosmesis. So this is very important in the world of breast cancer, for example, where we want to make sure that the treatments that we give a patient to actually cure them of their cancer also helps maintain their cosmesis, especially from side to side. Additionally, sometimes in terms of cancer therapy, we're actually just improving the patient's quality of life. And so this is often seen in the metastatic setting where patients have their cancer and it has spread to, say, their bones or their lung and so forth. And cancer therapy can often palliate symptoms that a patient is having, such as bone pain as a result of cancer being in the bones. We can also do this by talking about organ preservation as well. So for example, in bladder cancer, patients can either have a cystectomy or removal of the bladder for their cancer therapy, or they can actually undergo an organ preservation approach where we give them chemotherapy and radiation and the patients can preserve their bladder. With all of this being done, though, we of course want to maximize our impact on the patient's quantity of life. So we want to cure patients and help them live as long as possible, or maintain their remission for as long as possible. And then lastly, we want to also try and improve our cancer outcomes. So not all cancers have great outcomes, like, for example, early stage breast cancer. So we want to continue to do research to help improve these outcomes for our patients. So the discipline of radiation oncology really intersects with a lot of different fields. So radiation biology, which we have pictures here at both the molecular level as well as the animal level. At University of Maryland, we do research not only on small animals, but also on large animals as well. Physics is an important part of radiation oncology, as well as the clinical aspects of delivering the radiation therapy. And these all intersect and are important in our field. So just going over some of the basics of radiation oncology physics. So the physics of radiation oncology, so what is radiation? So this is a definition which is in kind of one of our radiation therapy handbooks, but the complete process by which energy is emitted by one body, transmitted through an intervening medium or space, and absorbed by another body. So there are various types of radiation therapy, and they're divided on this slide into kind of the naturally occurring types of radiation, which we consider to be alpha particles, beta particles, and gamma particles, or gamma rays. And then we have kind of more man-made particles like photons and proton therapy. So alpha particles are like a helium nucleus, so they are heavy particles and can actually be stopped essentially by a piece of paper. So if everyone remembers back in Japan a couple years ago when we had the nuclear disasters, actually by wearing clothing on a person's skin, they could actually block alpha particles from hurting them. Beta particles can actually go through mediums a little bit farther than alpha particles, but still can be blocked essentially by a piece of aluminum, and they don't travel as far. We often think of beta particles as traveling only a couple millimeters, and this is actually how when we give prostate implants with seeds for patients, mostly what's emitted is beta particles. And then lastly, there's gamma rays, which are basically the way radiation therapy used to be delivered in the 60s and 70s. We had machines called cobalt machines, and the cobalt source would actually decay and emit gamma rays. And that's how we actually used to treat patients with radiation therapy. Gamma rays actually need a much bigger medium in order to stop them. And so here you have a piece of concrete. And so just for reference sake, in our radiation therapy vaults, there's often actually 6 feet of concrete, which is used to help stop any potential emissions to patients. When we look at gamma rays and we talk about photons, which is really how radiation therapy is delivered nowadays, photons have very similar properties to gamma rays. But again, the difference is that gamma rays are naturally occurring. So when we talk about, well, where are we on the electromagnetic spectrum when we're talking about radiation therapy, we're over here in the left area here. Okay, so again, we can't see gamma rays or photon energies. So how are X-rays generated? So on the left here is a diagram of actually an electron tube. So this probably reaches back to a lot of our physics from high school or college. But basically you have an anode and a cathode. You apply an electric current to that and you can create X-rays. This is what the modern day radiation therapy machine looks like. And so basically this is the head of the machine where the radiation therapy is emitted from the machine. This is the treatment table that the patient lies on. And both this part, which is called the gantry, can rotate around the patient in a 360-degree fashion. And then the treatment table has 6 degrees of freedom. So it can move in and out, left and right, and up and down. And in even more modern tables, we actually can also do some rotational changes as well. So the modern day radiation therapy machine is actually called a linear accelerator, which we abbreviate and call it a LINAC. And so basically what happens is these machines can generate high energy photons as well as electrons. And what actually happens is there is an electron gun inside of the treatment machine. The electrons are then accelerated in what we call the waveguide, which is seen right here. The electrons then get put through a bending magnet to actually have the energies come out this way. And what happens is those electrons strike a piece of metal. They then undergo what's called a Bremsstrahlung reaction and then create photons. And those photons are then emitted through the head of the machine. And they're shaped by what we call different collimators to create various shapes. When the radiation beam exits the machine, it's filtered in a couple different ways so that we have a uniform beam characteristic. So that means as you go from side to side of the beam, the X-ray energy is exactly the same. We can do precise field shaping up to about ½ cm now. And then we can have precise delivery, again, with the rotation of the gantry, the couch, and then also patient immobilization, which we'll get into in a little bit. So when we do radiation therapy planning, there's really kind of 2 techniques that we now use for radiation therapy planning. One is called 3-dimensional conformal radiation therapy, or 3D CRT. And the other main one that we commonly use now is called IMRT, which we'll also get to in a second. So when we talk about 3D conventional radiation therapy, basically the patients undergo a planning CAT scan. On that CAT scan, we can draw out where the tumor is located, also where the normal organs are located. And then we create multiple different beam angles to deliver radiation therapy to the patient. So in this example here, each of these boxes is supposed to represent a different beam angle from the radiation therapy. And all of those then converge onto the central point here to deliver the radiation therapy. The CAT scan that we perform allows us to basically create a virtual patient in that manner. IMRT, on the other hand, stands for intensity modulated radiation therapy. And this basically gives us a little bit more of what we call a dose cloud and is a lot more of a complex type of radiation therapy and requires what we call inverse planning. So when we talk about inverse planning, what that actually means is that before we actually go ahead and start trying to figure out, well, how do I want to deliver the radiation treatment in terms of the beam angles and so forth, we basically tell the computer, well, I want the tumor to get this amount of radiation, and I want the surrounding organs to get different amounts of radiation. So for example, if I wanted to treat the bladder to 50 gray, I can tell it, the tumor to 50 gray, but I want to keep the bladder, which is right nearby, at 20 gray. We give all that information into the computer, and then the different treatment planning softwares have different algorithms which they can use to actually create a radiation plan. And so what actually happens is from different beam angles, you might get these funny shapes and patterns, which are demonstrated here. And those all converge on the single area and create what we call a fluence map, which is right here. And so with that, we're able to get a very high dose of radiation therapy to the tumor with minimal to no doses of radiation to the surrounding structures. This is commonly used in head and neck cancers where we have a lot of critical structures adjacent to tumor. So in this example, this is a sagittal slice of a patient. In the red area here, it's supposed to represent the tumor. And we then have important areas nearby, the spinal cord, the brain stem, some of our swallowing structures, our airway, our oral cavity. And so the radiation planning software can basically, again, modulate the dose so that we get a very high dose of radiation here with minimal to no dose anywhere else. And each of these areas here represents a different fluence map of what that beam would actually look like. Another type of radiation therapy is called brachytherapy. And basically what brachytherapy is when we are able to place a radiation source inside or adjacent to the tumor. When we do this, it allows for rapid dose fall-off, which allows maximal sparing of the normal tissues, but very high doses of radiation to the tumor itself. And brachytherapy is commonly used for certain tumors, such as those in body cavities. So basically a lot of the GYN malignancies, cervical cancer, endometrial cancer, vaginal cancers, as well as sometimes for head and neck cancers, such as in the nasopharynx. And brachytherapy is also used for tumors that are very close to surfaces. So for example, prostate cancer, sarcomas, sometimes tongue cancers, lip cancers, and even breast cancers. So this is an example of a brachytherapy plan for a patient who has a uveal melanoma. And this is what we call an eye plaque, where we basically can place a little shield on the eye, which delivers radiation therapy for a brief period of time. Here's another example of a cervical cancer patient receiving brachytherapy. And so the device here is something that we call a tandem and ring. So the straight piece here is called the tandem. The circular piece here is called the ring. And basically, these are two hollow instruments. And through the hollow instrument, a radiation source travels up into them and then stops and delivers radiation therapy for pre-specified amounts of time based on our radiation therapy plan. If you looked at a CAT scan or the treatment planning scan for a patient undergoing this type of implant, this is a coronal image here, and so each of these little dots here represents a space where the treatment planning software has said we want to deliver radiation, and then these lines, which are probably difficult to see, show the isodose lines for the radiation distribution. And what you can appreciate is that here, close is a very high dose of radiation, but within about 1 to 2 centimeters, there's what we call a very rapid dose fall-off, so essentially minimal to no radiation dose getting past that area. Another type of radiation therapy, and that's a little bit different, is also called stereotactic radiosurgery. And so this technique of radiation therapy used to only be around to treat brain tumors through a treatment machine called the Gamma Knife. And what you see here on the upper image is actually what would be a Gamma Knife plan. And basically what happens with the Gamma Knife is that there's 201 different sources that all converge on a single point. So I usually tell patients, if you drew 201 lines all intersecting at the same point, you get a very high dose of radiation right in the middle of all those intersecting lines, but essentially a minimal to no dose of radiation through any one of those beam paths. And so stereotactic radiosurgery, the concept of that is that we're basically providing the effect with radiation that you would with surgery if you actually were to take that tumor out. It's that precise. Now, stereotactic radiosurgery in the last 10 years or so, the technology's developed significantly where we can now treat tumors in other body sites as well using the same type of technique. And we call this stereotactic body radiation therapy, or we abbreviate it SBRT. And this is commonly now used to treat lung cancers, liver cancers, as well as bone cancers, and sometimes even some other GI organs. And the thing that's most important about delivering stereotactic radiosurgery is the ability to immobilize the patient. So we have to make sure that what we're actually aiming at stays nice and still. And so this is an example here of a lung plan. And stereotactic body radiation therapy for lung tumors is actually now so successful that it's actually challenging the paradigm of giving surgery to patients for early stage lung cancers. And then I always like to point out, because oftentimes people have heard of this, that CyberKnife is actually the brand of a machine that delivers stereotactic radiosurgery. But there's lots of other types of radiation therapy machines that deliver that same type of therapy. But oftentimes now the word CyberKnife has become synonymous with this as well. So a little bit on the basics of radiobiology. So switching gears. So this is what a radiation cell survival curve looks like. Okay, and so on the y-axis here you see a logarithmic plot, and on the x-axis you see doses of radiation. And what you can see from this figure on the left here is that we have two different types of radiation particles, so alpha rays and then X-rays, which again are somewhat synonymous with gamma rays. And what you can see is that alpha rays, or alpha particles, are what we call densely ionizing. They're big particles, they stop everything in the track that they hit. And so what you can see is that with small doses of radiation therapy, you get a very high degree of cell kill. Conversely, when you look at photons or X-rays and you give different doses of radiation therapy, what you can see is that you have to get to a pretty high dose of a single fraction of radiation therapy to get an equivalent logarithmic value of cell kill. What you can also see from this is this ratio here, which we call the alpha-beta ratio. And so each type of tissue, both tumor tissues as well as our normal tissues, has a unique inherent property that we call the alpha-beta ratio. And this basically helps tell us how sensitive that tissue is to radiation therapy. So generally speaking, tumors have an alpha-beta ratio of somewhere between 8 and 10, whereas our normal tissues, we say, have alpha-beta ratios somewhere between 2 and 5. On the right here, what this figure is also kind of showing us is that there's what we call a shoulder to the radiation therapy. So if you look at this curve here for the X-rays, and you see kind of where, if you were to draw a straight line up from this area, this is what we call the shoulder of radiation. And so basically what that indicates is that you have to get over a certain threshold of the radiation therapy before you get a significant amount of cell kill. Now, when we give radiation therapy, we're not typically giving one large dose of radiation. We give multiple fractions over several weeks. And the reason that we do that is what you see here. So by fractionating the radiation therapy, it changes what our cell survival curve looks like and allows it to look more linear or more like those alpha particles that I just showed you. And so this is actually the reason why we fractionate radiation therapy. The other reason is that this allows us to take advantage of the fact that our normal tissues can actually pair those minimal amounts of radiation therapy that happen on a daily basis. So our tumor will look like this, whereas our normal tissues will have a different type of curve. Okay, so that's what's supposed to be demonstrated here. So when we talk about radiation biology, there's what we call the 4 R's of a fractionated radiation therapy regimen. They're repair, reassortment, also known as redistribution, reoxygenation, and repopulation. And we'll touch on each of these a little bit more as we go through. But in terms of repair, so our healthy cells or normal tissues are actually able to repair DNA damage that happens during each treatment of radiation therapy. So do our tumor cells. But inherently, because tumor cells are tumor cells, they have some sort of defect in their DNA repair pathways, which I'll show in the next slide. And so this preferentially allows our healthy tissues or our normal tissues to repair the DNA damage where our tumor cells are not able to do so or not able to do so as effectively. In terms of reassortment, so radiation therapy actually causes cells to accumulate in certain phases of the cell cycle. So we'll talk about that a little bit more in a second. Reoxygenation, so tumors actually reoxygenate after they've been exposed to radiation therapy. And then repopulation, so both tumor and normal cells can actually repopulate between doses of radiation therapy. And so basically this is why when we give radiation therapy, we want to give it over consecutive days and not give you one fraction 1 week and another fraction the next week, because basically those cancer cells can regrow in that time frame. So when we talk about repair, so DNA is really the primary target of radiation therapy. And there's two different actions of how DNA is the primary target. So one is what we call the indirect action, and the next is the direct action. So when we talk about the indirect action, that's best seen on the top of this figure here. So if you have a photon energy coming in, it knocks an electron off, and that electron creates some sort of free radical. It's then actually that free radical that goes and causes some DNA damage, okay? And so that's what the indirect action is. And this is probably, this happens most when we give radiation therapy. In terms of direct actions, what can happen sometimes is the photon energy can come in, it can knock this electron off, and that electron can directly go and damage the DNA. Similarly, if we give particle therapy or proton radiation, protons are much bigger particles than electrons, and the proton itself can actually directly damage the DNA. We can have two different types of DNA damage, so what we call single-strand breaks or double-strand breaks. And double-strand breaks are really key in what we're looking for in radiation therapy. Unfortunately, double-strand breaks are actually the least common effect that happens when we give radiation. So as I mentioned, this oxidative damage is the thing that happens the most. Secondary are these single-strand breaks, and so those happen on the order of thousands for every gray of radiation that we give. And when we give 1 gray of radiation therapy, double-strand breaks, there's typically only 40 per gray of radiation therapy delivered, okay? Single-strand breaks are much more easily repaired by two different processes, which we call non-homologous and homologous end joining repair. So when we talk about redistribution or reassortment, so another thing that happens when we give radiation therapy to patients is that because the radiation therapy induces DNA damage, the cell will actually pause in its cell cycle to be able to repair that DNA damage, because if it continues to go on through the cell cycle, it will die. And so this is just one example of some pathways that happens when we give radiation therapy. But what you can see here and here is that these can both cause cell cycle arrest in different parts of the cell cycle. So if we look at kind of the cell cycle here, there's two different checkpoints, one the G1 checkpoint and the G2 checkpoint. And so radiation therapy can cause cells to accumulate in both of these areas while it's repairing the DNA damage that's occurred. This has become actually a therapeutic target now, and so there's drugs in development that are currently being tested in multiple phase 1 and 2 trials called checkpoint inhibitors to try to basically exploit this part of the radiation therapy process, as well as the chemotherapy process. To make that a little bit more complicated, we also know that radiation therapy cells are much more sensitive to the damage that radiation therapy can cause in different parts of the cell cycle. So in particular, the M phase or mitosis and G2 phases are the most sensitive to radiation therapy damage. And that's basically because in those parts of the cell cycle, the DNA is much more condensed and more coiled. And so if you can imagine, as you have a photon energy passing through there, with the DNA being coiled and close together, there's a much higher likelihood that it can cause that direct damage. When you look at some of the other phases, so this is what the cell survival curve here is showing as well. So M and G2 are the most sensitive, followed by G1, and then early S and late S phases. The other thing we talked about is reoxygenation. So again, if you have tumor, the farther it is from a blood vessel, that part of the tumor will have less oxygen or be more hypoxic. And we know that the areas of tumors that are hypoxic are more resistant to radiation therapy. So the more oxygen it has, the more damage it can also cause in terms of that oxidative damage, as I mentioned. So there's different ways when we take all of that information into account, well, how can we make the radiation therapy work best for us, okay? And so there's different ways that we can modify the radiation therapy. The first is through what we call radiosensitization. So we have two graphs here. The top curve here is the tumor curve, and we're looking at tumor control probability over dose of radiation delivered, and the right one is normal tissues. And so in the example here, if we gave 60 gray of radiation therapy, this might result in 65% local control and only 15% normal tissue damage. If we give some sort of radiosensitizer, what we actually do is shift this curve back, shift the curve. And so if we're giving the same 60 gray of radiation therapy, we can improve our local control while maintaining the same degree of normal tissue damage. And so the most common way that we radiosensitize tumors is actually by giving patients chemotherapy. And what happens when we give chemotherapy is when you actually look at this cell cycle here, chemotherapy will preferentially place cells into this G2 and M phase, depending on the type of chemotherapy. So that allows us to have more damage when we're giving the radiation therapy. Similarly, another idea is giving radioprotectors. So again, kind of the same types of curves here, but instead here, what happens is when we give a radioprotector, we can actually escalate the dose of radiation therapy potentially, and then that's the way we can actually improve the local control while again maintaining the same degree of normal tissue damage. Now, in reality, the different areas of research that have really looked at different radioprotectors hasn't been as fruitful in terms of providing different drugs that we can give to patients as giving chemotherapy in terms of radiosensitization. But this continues to be an area of active research, not only for cancer therapy, but also for protection of all of us should any disasters occur. So when we look at what are some of the radiation therapy targets, so there's lots of different ways that we can target cells to help them be more sensitive to radiation therapy damage. So there's single agent targets such as growth factor receptors, EGFR and VEGF receptors. So there's actually inhibitors to both of these drugs that have been developed and can be used safely in combination with radiation therapy. There's been areas looking at DNA repair proteins, transcription factors, as well as signal transduction proteins. But as many of you know, these pathways are often very, very complicated, and there's not one single direct area that we can target the pathway to inhibit it. There's also what we can do is multi-target inhibition, so looking at chaperone proteins, looking at the microenvironment with angiogenesis and the blood vessels, and again, this is been done somewhat successfully with the introduction of the drug bevacizumab, as well as epigenetic modification. And then there's also radiation-inducible targets as well. So this is just one example of an EGFR receptor as well as the VEGF receptor. And we can see how complicated all of this is. And what you can see here are some different drugs which have been used to target these different areas. Bortezomib is often used in some of the leukemia and lymphomas, celecoxib, and so forth. But when we're developing drugs to help use with radiation therapy, some of the issues for target and agent development are really the mechanism of how the drug is going to act. So what types of cells are we going to act on? Are we going to act on the surface cells? Are we going to try and act on the cells more in the center of the tumor? Or are we going to try and have these targets and agents work on specific types of cancer? So just kidney cells, for example, if it's a renal cell carcinoma. We can also look at the method of targeting. So are we going to look at the antibodies and an antibody that can attack their receptor? And again, this has been successfully with the EGFR receptor and the VEGF receptors. Are we going to try and use some small molecules, so like Gleevec, which has been used in CML, or gene therapies as well? And then we also have to consider the therapeutic ratio. So we want to make sure that we're killing more tumor cells than normal cells. So moving on to clinical practice of radiation therapy. So again, some of our goals of radiation therapy are obviously to cure cancer. So if the cancer is localized to one organ or region, we can aim our radiation beam at that to help cure the cancer. We also, as I mentioned before, talk about palliation. So again, in patients who have metastatic cancer, we can palliate any symptoms that they may have, such as bone pain from bone metastases. If a tumor is growing on someone's airway and causes their lung to collapse, we can give radiation therapy to help open that up. Or if patients are bleeding from, say, a cervical cancer, we can give them radiation therapy to stop the bleeding as well. This list is by no means comprehensive, but here's some of the lists of cancers that we can cure with radiation therapy. So prostate cancers, bladder cancers, breast cancer, lung cancer, head and neck cancers, gynecologic malignancies, pediatric cancers, CNS cancers, skin cancers, and lymphoma should be on here as well. And then again, some of the things that we palliate: bone pain, shortness of breath, neurologic symptoms, and then again, pain from other lesions due to space issues. So radiation therapy doesn't operate in a vacuum. It's an integral part of the oncology team. And this just gives a sense of some of the other disciplines that help us take care of our patients. So medical oncology, surgery, social work support services, other specialties, radiology, pathology, and even primary care physicians. So we all have to interface with one another in order to take the best care of our patients. So when we're giving radiation therapy, the first thing we have to do is develop what we call a multimodality plan. So there are pretty few cancers that are treated by just one modality alone. Oftentimes we're combining radiation therapy with surgery or surgery with chemo and radiation therapy. And so we often all have to meet together to develop a plan for the patient. This is often done best in what we call the multidisciplinary setting. So a lot of hospitals, including here, when we see new patients, the whole team of all the doctors will actually meet together either before or after the patient is seen and talk with one another before presenting the patient with their final treatment plan. Sometimes there's also other localized therapies that are included for the delivery of the treatment plan, including what we call focal ablation techniques. So this can be done through like microwave treatments or cryotherapy, as well as ways that we can give what we call focal drug delivery. And so sometimes we actually now have some particles that we can attach radiation modifiers to and deliver that, and radiation therapy is just delivered to where that molecule is delivered. That's similar to what we call Sear spheres. So what happens in the radiation therapy process? So first, the patient is seen by us in consultation, whether it's just us or in that multidisciplinary setting, as I mentioned. Once we determine that the patient should undergo radiation therapy, they undergo what's called a CT simulation or a planning session. And at the time of the CT simulation, what we like to do is simulate the patient in the exact way that we want to deliver their treatment. So depending on the type of cancer, that might vary. So for example, in anal cancers, I might have the patient lay on their belly or in the prone position. For breast cancer patients, I typically would have them laying on their back with their arms above the head, like you see in this picture here. But sometimes I actually may also lay them in the prone position so the breast is hanging in a dependent position. At that time, we'll also make some immobilization devices so the patient can lay in exactly the same position each day. And we also place marks on the patient's skin so that we can line them up each day using lasers within the room. I always just mention this more because it's fun, but radiation, we used to give tattoos to patients to actually line them up each day, and that's typically not done anymore for the patients. Once the patient undergoes their CT simulation, we then transfer those images to the treatment planning software. And then sometimes if we need to, we actually can fuse other images to that treatment planning software so we can better delineate the targets. So for example, a PET scan, an MRI scan, or even other CAT scans. Once that's done, we actually do what we call contouring. So we draw where we want to deliver the radiation, so the tumor, some of the lymph node regions, depending on the type of cancer. And then we also will contour out any of the normal structures that we're worried about in that area. A plan is then created by a group of people called dosimetrists. And then once that plan has been created, I, as a doctor, come and evaluate the plan. If I like it, we move forward. And then that plan is also evaluated by medical physicists to look at the different physics properties as well. Once everything looks good, we then would transfer that plan from the treatment planning software to the software that delivers the radiation therapy treatment, and then the treatment is actually delivered. As I mentioned a little bit ago, oftentimes for treatment, we give the treatment over one fraction per day, typically over many, many weeks. And for each type of cancer, a different essential dose of radiation therapy has been determined to be sufficient in terms of curing the cancer without causing too many side effects. And so depending on the type of cancer, that might range anywhere from about 3 weeks to up to 7 to 8 weeks, for example, in prostate cancer. The treatment is actually delivered, as I mentioned, one fraction per day, and we do that typically 5 days a week. Patients typically get the weekend or 2 consecutive days a week off, and that actually allows for normal tissue repair in between fractions as well. So this is just an example of one of the patients that I recently was planning. So this is a head and neck cancer patient who had an oral cavity cancer. He underwent surgery and now is coming in for his radiation therapy. And so what you can see is that typically now in our treatment planning software, we can contour actually in all different planes. So this is an axial slice, a sagittal, and a coronal. And we can draw out where we want to deliver the radiation. So this is actually where the patient had their original tumor and where they had their surgery. And then, for example, the parotid gland, what you see here, is an area that I want to spare from radiation therapy. Okay. So moving on to a couple patient presentations as well. So again, we'll kind of walk through each of these steps that I just mentioned. So this is a 55-year-old female who developed a new lump in her left breast. Because of the lump on the breast, the patient underwent a mammogram, which showed a suspicious abnormality. And this was biopsied and consistent with the most common type of breast cancer called infiltrating ductal carcinoma. The patient did not have any family history of breast cancer. So the patient's discussed in the multidisciplinary clinic, and then there's various treatment options that this patient could undergo. So for breast cancer, we oftentimes are giving all three modalities, so surgery, chemotherapy, and radiation therapy. And so the patient has a couple different options in terms of her surgery. So she could undergo a mastectomy or removal of the entire breast, okay? And this is what, not anymore, but kind of back 30, 40 years ago, a mastectomy would look like, where they removed the breast, but they also removed the pectoralis muscle, and so it was quite deforming for the patient. Nowadays, we don't typically remove the pectoralis muscle unless it's actually involved with cancer. Or the patient could undergo what we call breast conserving therapy, which consists of lumpectomy and radiation therapy. So in a lumpectomy, we see where the tumor is, and we remove the tumor plus some normal tissue around that area. So the patient in this scenario selects breast conservation, and we think that that's important because that allows patients to maintain their cosmetic outcome, which is very beneficial for patients. So they undergo a lumpectomy and what's called a sentinel lymph node biopsy, where they basically inject radiotracers into and around the tumor. You allow that to sit in the patient for a couple hours, and kind of it will drain to the what we call the sentinel lymph node in that area. And so in the operating room, we can actually detect where that sentinel node is located by using a small probe, as well as sometimes they inject some blue dye as well. And so the surgeon can actually remove those first draining lymph nodes of the breast cancer. So at the time of pathology, in this example, the pathology reveals a 3-centimeter tumor, which would be a T2 tumor, as well as 4 axillary lymph nodes that are positive. So because this patient has some positive axillary lymph nodes, they would then receive chemotherapy following their surgery. And then after that, the patient would need radiation therapy in order to give them the best outcomes and chances of cure. So in terms of radiation therapy, again, we have a couple different things we have to think about as a radiation oncologist. So how am I going to deliver the radiation therapy? Is it going to be through external beam radiation therapy or brachytherapy, again, where we can put sources kind of into that area? With radiation therapy, we again have different types of radiation, so photons and electrons, which are kind of the more standard type of radiation therapy, or proton radiation therapy. In terms of brachytherapy, we talk about what's called sealed sources, so those sources that are basically kind of contained in something, so that, let's say, if you spilled it, it wouldn't spread everywhere, or unsealed sources as well. And so this is an example here of what brachytherapy would look like for a breast cancer. So as you can see, it looks probably not too comfortable, so we actually don't do this very often for our patients for breast cancer anymore. The patient would then undergo, so let's say we elected to undergo external beam radiation therapy, the patient would then undergo their CT simulation. So you can see here this patient is laying on their back and their arms out to their side, and this is where the breast tissue is located. We put these little markers outside on the skin to help us line up the patient at the time of the planning scan. We subsequently remove those. We don't need them for everything. And then here's where we actually would figure out, well, what beam angles do we want to use? What size of beam? What energy of radiation therapy do we want to use as well? So we then create the plan, and again, the dosimetrists help us do this. And then what you can see here in this plan is there's one beam coming from this way, which we call the medial beam, one beam coming here from this way, which we call the lateral beam. And what we're balancing, especially in breast cancer, is trying to avoid the heart, which is right here in the middle, and then minimizing the amount of lung tissue that's in the field. And so in this plan, this little thin red line is the 100% isodose line, and so we're looking for that to basically cover the whole breast area. We would then deliver the treatment. So again, this is an example of how a patient might lay for a breast treatment. And during the treatments, we also take X-ray images, at least on a weekly basis, to confirm that the patient's in exactly the same position. So we don't just take what we call their skin marks to be the only source of alignment. And so here, what this shows is it's actually also confirming what the beam looks like on a weekly basis as well. So the next example is a patient, a 54-year-old male with an elevated PSA on routine screening exam, which is the most common way we find prostate cancer nowadays. The patient's otherwise healthy with no other medical problems. And on biopsy, we find what we call Gleason 6 disease, or the lowest risk prostate cancer. So again, you talk about developing a treatment plan, and for what we call low-risk prostate cancer, there's actually a lot of options. So I should have included on here as well what we call observation or active surveillance. The patient could undergo surgery. They could potentially need surgery and radiation if at the time of surgery we find some high-risk features. In terms of radiation therapy, there's a lot of different options as well. So again, brachytherapy, external beam radiation therapy, or a combination of therapy, or sometimes for what we call intermediate and high-risk prostate cancer, we might give radiation therapy in combination with hormone therapy as well. So this is an example of a brachytherapy plan for a prostate implant. So this is actually a patient I did last week. And so what is drawn out here, but it's hard to see, is that this kind of darker gray area is actually the prostate. And then what we do in the computer is we basically place needles directly into the prostate through the perineal skin. And each of these kind of green dots represents where we've placed a seed in the planning software. And then here you see the isodose line. So this blue line here is the 50% line. So you can see that between here and here, which is only about, it's less than a centimeter, there's only 50% of the radiation therapy that's getting to the other tissues in that area. And then the red is the yellow here is the 100% isodose line, which is actually covering the whole prostate. Here is an example of an external beam patient who's getting prostate radiation therapy. So this is another one of my patients, and you can see here. So the red here is actually the prostate. The blue is what we call the PTV margin, or planning target volume margin. And so basically what we do for all of our patients who are getting external beam radiation therapy is we put two separate margins onto where we see the tumor. So one is called the CTV, or clinical target volume. And the idea behind that is to account for what we call microscopic extension of disease. So the disease that we can't see on the CAT scan. And there's some nice pathologic data depending on each type of cancer to indicate what that is. So for example, for certain lung cancers, we know that for squamous cell carcinomas, if you actually took it out, there can be some microscopic extension about 6 millimeters outside of what you would kind of see on a CAT scan. The planning target volume then also accounts for what we call setup error. So day to day, even though we have all these great tools to set the patient up, we know that we're going to be off within a couple millimeters on any given direction. And that also accounts for internal motion of organs as well. So for example, for prostate cancer, if a patient's bladder is really full, it might push the prostate a little bit of a different way than it would if the bladder was a little bit empty. And so here what you can see is this yellow structure here is the bladder, and this is the prostate, and you can see the isodose lines carving really nicely around the prostate. The other thing that we also do nowadays is what we call image-guided radiation therapy. And so for prostate cancer in particular, the things that we look at are tools called Calypso, or also gold fiducial markers. Additionally, we have something called cone beam CAT scan as well. And so that's basically on the treatment machines nowadays. We can actually do a mini CAT scan on the treatment machine to confirm where all the organs are located, make sure, say, the bladder is as full as I want it to be, make sure there's no gas in the rectum, and so forth. It also allows us to monitor the tumor, so we can see if there's drastic kind of tumor shrinkage or drastic tumor growth too, so that we can actually modify the radiation plan while we're actually treating the patient. So what Calypso is basically there's 3 radio transponder beacons that can actually be placed into the prostate. And this allows us to do what we call intrafraction monitoring, where basically we're monitoring where those transponder beacons are located while the patient's actually having their radiation therapy delivered. And so if, for example, the patient passes a lot of gas on the table and that causes the prostate to move, we can actually stop the radiation beam while that movement is actually occurring. Gold markers, which you can kind of see here, can also be placed in the prostate, and this can allow us to triangulate the exact location of the prostate before treatment and account for what we call interfraction motion. And so what happens here is these are some X-ray or KV images that we take each day for the patient prior to treatment. And so on the left here is what happened at the time we did our planning scan, and on the right here is what happened that day on the treatment table. And so we're looking for those 3 little gold markers to be in exactly the same type of position. And if they're not, we can actually move the table to make that happen for the patient. And this is an example of what I was mentioning when we call it a cone beam CAT scan. So it's a little bit easier to appreciate here on this sagittal image. But what you can see is that this yellow line here is what the bladder looks like at the time of the planning scan. And then I actually have a little window box that I'm outlining here with my cursor that actually shows what's going on right there while the patient's on the treatment table. And what you can see while the patient's on the treatment table is this is their bladder now. So we can actually see that their bladder is not as full as it was on the day of the planning scan. And so in this scenario, if the prostate wasn't lining up the way we want it to, we'd actually have the patient get off the treatment table, drink more water, and then we'd repeat the scan and see if it actually matches up now. So then, of course, we would deliver the treatment for this prostate cancer patient. So this is an example of a patient under treatment. So is it all that easy? This is getting to the point that radiation therapy isn't without its own side effects. So the things to remember about radiation therapy side effects are that they're all local. So we only affect the areas that we're aiming the beam at. And they're also cumulative for the patients, meaning at the beginning of the therapy, the patient doesn't have any side effects. As the therapy goes on, they develop, and then once the therapy is done, they taper off again. So I usually tell patients it's a little bit like a bell-shaped curve. Patients can have acute side effects, and this is again due to normal tissue damage, which the body then repairs over time, as well as some potential late effects as well. The short-term effects generally don't start for the first couple weeks of therapy, and then I usually tell patients it's really that second half of therapy and the couple weeks thereafter that are the hard parts, and that's where their body's actually healing. But for the majority of the time, most of the patient's acute side effects are all resolved within a month after the radiation therapy is done. Late effects, on the other hand, don't typically occur during treatment, but can happen months and even years down the line. So, for example, for late effects for prostate cancer, sometimes down the line, patients can develop what we call urethral stricture, where they can develop a little bit of scar tissue in the urethra, making that tube a little bit more narrow, so they might feel like they have to force the urine out or that they're not emptying their bladder fully. The good news is that for the majority of these late effects, we have something that we can do about them to help get rid of them, but oftentimes they generally have to do with the formation of scar tissue. And there are times where we can't reverse that or can't help that. Most of these toxicities, though, if you kind of classify them into different groups, have to do with stem cell depletion, chronic oxidative damage, vascular destruction, or fibrosis. And then the important thing to remember is that radiation therapy, as I mentioned earlier, is really dosed to normal tissue and not the tumor. So it's all about how much dose can we give to the tumor without hurting the normal tissues. And generally speaking, what we look at is the risk of 5% of patients developing an injury at 5 years is what we typically look at. So if we talk a little bit about lung fibrosis, so this is something that can happen down the line for patients. This is an example of a patient who got treatment actually in the early 1990s, which is really not the technique that we deliver radiation therapy a lot anymore. But what you can see is this is what the field actually looked like. So it was kind of this rectangular box. And what you can see in the patient on their CAT scan is you can see all this white stuff here and here is fibrotic damage from the radiation therapy. And it's in exactly the same shape as our radiation field. Fibrosis is thought to be mediated by a molecule called TGF-beta, and there's a lot of work being done on how to mitigate the effects that TGF-beta has to prevent pulmonary fibrosis from happening. But once pulmonary fibrosis occurs, there's typically nothing that we can do for that patient. The good news is nowadays we don't see this very often, but it occasionally does happen. Another example of something that can happen due to vessel damage is lymphedema. So here, for an example, is a breast cancer patient, and we can see that their right arm is significantly bigger than their left arm. Now, oftentimes for breast cancer, this isn't purely due to radiation therapy. This is also due to a combination of having their lymph nodes removed or a lymph node dissection. But radiation therapy, we say, typically increases that risk in breast cancer patients by about 10% or so. And so basically what can happen is you get some scar tissue that happens around the lymphatic channels, and so the lymphatic fluid just can't drain as well. These patients are often treated with physical therapy and massage and so forth, or compressive sleeves, and often do quite well down the line. An example of a short-term reaction is mucositis, which has to do with stem cell depletion. So when we give patients radiation therapy to the mucosal surfaces, as we see in this picture here with head and neck cancer, what can happen is that normal mucosal lining becomes disrupted, and you can see these whitish areas or a little bit of bleeding as well. And this is one of the side effects that we manage a lot during radiation therapy in terms of pain control and so forth. But fortunately, this resolves typically within 3 to 4 weeks after the radiation therapy is done. So where do we go from here? So radiation therapy has really evolved a lot in the last 60, 70 years or so, from the development of the first LINAC down to IMRT, and we're continuing to see a lot more advances as well. So in terms of the future of radiation oncology, again, we can look at it through 3 different areas. So biologically, so how can we use radiation to induce targets for other agents? How do we get better radiosensitizers as well as potentially radiation protectors? Can we combine new targeted drugs or monoclonal antibodies to radiation therapy, and is that safe or not? So there's lots of research going on in all of these areas. In terms of the physics of radiation therapy, how can we improve our treatment delivery? So how can we make our radiation beam even more precise than it was before? How can we account for better organ motion? So with the lung moving as we're breathing, how can we try to immobilize the lung tumor a little bit better? And how can we also improve our targeting, maybe by fusing additional imaging studies or using our cone beam therapy or cone beam CT scans to adapt our radiation therapy planning? And then in terms of clinically, how can we translate some of the exciting lab findings that many of you here are working on to help improve the outcomes for our patients? So in terms of some of the newer modalities of radiation therapy, some of the stuff that's out there now, so there's some radiopharmaceutical therapies where we, again, basically can attach radiation therapy particles to different chemotherapy agents. So that's what Zevalin and Bexar are. Or sometimes we can deliver radiation therapy through what we call unsealed sources into the bloodstream, and that can congregate into areas of tumor. So we do that sometimes now in metastatic prostate cancer with radium-226. This is an example here of CyberKnife, which I mentioned earlier, which is a radiation therapy machine that basically operates on a robotic arm. So again, can kind of deliver radiation therapy through any potential beam angle. And then proton beam therapy as well. So in terms of proton therapy, I just wanted to take a minute to mention that because we'll be having a major center open in the region in the next month. So proton therapy has a little bit of a different physical property than photon radiation therapy. So what this graph looks like here is, so the blue area here is what we call regular or photon radiation therapy. And what you can see is as the dose enters the skin, so this would basically be the skin surface, and this is as we're going into the patient's body. So at the skin surface, there's a lower dose of radiation. That dose then builds up in the tissues, and depending on the energy of the X-rays used, that's at a different depth for different energies. And then as we continue to go into the patient's body, the X-rays then, the dose decreases. So X-rays do not stop. They really pass through the patient. Proton therapy is very different in that it has a lower entrance dose, but we can basically stop the proton beam wherever we want it. Okay, so if we have tumor here, by choosing a different energy of proton therapy, we can basically stop it. And so what you see is there's not this tail that you see here with proton therapy. What this allows us to do is give radiation therapy to our target tissues and even further decrease the dose of radiation therapy to any of the normal tissues. And so this is a therapy that's thought to be particularly helpful, especially in pediatric patients or in areas where we have a lot of critical normal structures like head and neck cancers. So this is an example here of some work that we've been doing, and this is a breast cancer patient. And so it compares a proton radiation plan and a photon radiation plan. And so we might say, well, why are we worried so much about breast cancer? But what we see is that the heart is very close to the breast in certain women, as well as the lung tissue. And a big important paper came out 2 years ago that showed that for every gray of radiation we can minimize to the heart, there's a 7% less risk of having some sort of cardiac event, which they defined as a heart attack, need for a stent, or actually death from heart disease. So this is something that can potentially be a very important long-term effect for women. And so what you can see from the proton radiation plan here, so this yellow contour is the breast tissue, the red area is the high dose of radiation or what our prescription dose of radiation is, and the blue here is much lower doses of radiation, probably about 20% of the dose. And so we can see that the red area here gets a very high dose of radiation therapy, but importantly, the heart here is basically getting no radiation therapy. And these little gray circles here are actually supposed to be the coronary blood vessels as well. With a photon radiation therapy plan, what you can see is that a lot of this heart is getting this low dose bath of radiation therapy. And importantly, all those coronary vessels are all in that area as well. And what you can see here is this is basically a subtraction image where we've put this plan on top of this plan and subtracted it out. And you can see really all that difference is in the lung tissue as well as the heart as well. And so in this example, the proton plan could actually deliver much less dose to the heart, which we think, based on the more recent data, would actually have a clinically meaningful, significant impact on the patient's life in the future. So again, as I mentioned, the University of Maryland, in partnership with a private company called APT, is actually opening the Maryland Proton Treatment Center down in Baltimore. We'll be starting to see patients this next month and then actually turning the radiation therapy beam on in early January. And so this is thought to hopefully provide additional resources for our patients, in particular the pediatric population, where again, those long-term effects are, we worry about much more than, say, an elderly person. And our vision is to become a proton center of excellence across all the academic missions in terms of education, research, and so forth, but also be accessible to patients and partner with all of our regional health care systems and oncology providers. The facility itself is a $200 million facility with 110,000 square feet, 5 treatment rooms, and we, at the end of the day, will be able to treat up to almost 200 patients per day there. So the take-home messages, so radiation therapy is an important tool used in cancer therapy. Radiation, the way it works is by causing DNA damage, which ultimately leads to cell death. The effects of radiation therapy can be altered by modifying a lot of things, including physical factors, physiologic factors, fractionation drugs, and a lot of other variables. But radiation can cause some complications and side effects that we also have to manage. And I think most importantly, at least for me, radiation is interesting, especially in our era now with some of the new advances that are coming to the region. So thank you.
Question? Isn't the proton therapy good for patients with glioblastoma?
Yeah, so the question is if proton therapy might be good for patients who have glioblastoma. So the idea behind proton therapy, again, since it can actually be stopped at any place that we want it, is that in particular for brain cancers like GBMs or astrocytomas, is that it can actually allow us to potentially dose escalate, so actually give higher doses of radiation therapy to the tumor than what we can currently achieve in photon radiation because, again, of some of the surrounding structures like the brainstem, the optic vessels, or the optic nerves, sorry, optic chiasm, and so forth. So the idea is that, well, if we gave the same amount of radiation with proton therapy, it might not be better than photon radiation. Proton therapy will actually allow us to dose escalate, which in GBMs, there is some data to say that that might be beneficial in terms of curing patients. Okay. So the question is, what percentage of patients who have cancers get radiation therapy? So again, it depends a little bit on the type of cancer that a patient has. But when you take all in all, with the exception really of some of the leukemias and lymphomas, almost all cancers have some role for radiation therapy at a certain stage. So when we actually look at our patient populations, about 50% of the patients that we're treating are for what we call curative purposes, meaning as their initial treatment to cure their cancer. The other half of our patients, believe it or not, are actually patients who have metastatic disease, and we're palliating some sort of symptom as well. But a large majority of cancer patients do receive radiation as part of their therapy. Okay. So great question. Yeah, so the question was asking, you know, with radiation therapy or I think malignancies in general, wouldn't it be helpful if the immune system was boosted? And so you're actually right on the money. So radiation therapy, we know when it's delivered, does cause some sort of inflammatory reaction. A lot of different cytokines are released into the body system. And for certain cancers in particular, we have actually found that that immune response actually helps to help the cancer respond in all other areas of the body, and we call that what we call the abscopal effect. So most recently, that's been shown in melanoma treatment. So patients who have melanoma, we know that that disease in and of itself is somewhat modulated by the immune system. And there's a particular antibody therapy called ipilimumab that we've given to patients. And when you take that therapy alone, it does kind of help the cancer respond in all areas of the body. But interestingly, if we give radiation to a single site while they're getting that drug, we've seen responses in other areas of the body. So for example, if someone has a spot on their arm and we're giving radiation therapy in combination with the drug, a tumor in another part of their body will actually shrink even though we're not giving radiation therapy to it. So that's actually an area of active research is looking at how can we also harness the effectiveness of the immune system to further help our cancer patients and deliver the therapy. And drugs like ipilimumab and a couple other drugs that have recently come out are looking at exactly that. Okay, thank you all.
Okay, and our next speaker is Brid Ryan. So she got her undergraduate degree at the University of College Cork in Ireland. Subsequently, she got her PhD in cancer biology at the University of College Dublin. And then she came to the NCI Cancer Prevention Fellowship Program. She currently works with Kurt Harris at NCI and is a NCI Earl Statman tenure track investigator. So the title of her talk is The Causes and Consequences of Cancer Health Disparities.
Great. Thanks very much, Terry. Okay, so can everybody hear me okay? All right. So as Terry mentioned, I work here at NCI, so I did my postdoc here. And before I came to NCI, I came from Ireland, as Terry mentioned. And I really didn't pay all that much difference or attention to health disparities because I came from quite a homogeneous population, to be totally honest. So when I came here and I was doing research on lung cancer during my postdoc, we were doing translational molecular epi studies. And we studied populations that included both European Americans and African Americans. And so it started to become quite clear to me that there are disparities in both incidence and outcomes across many different cancers. And of course, for any scientist who observes that sort of thing, one of the key questions that you're going to ask is why do those disparities occur? So in the lecture today, what I'm hopefully going to do is to take you through some of the background to the field in general, and then discuss some of the disparities that exist in terms of both cancer incidence and outcomes, and to present you with some evidence from many different fields of science which are trying to address and overcome each of these disparities. Okay, I want to just mention something specifically at the beginning, and this is just to give quite boring definitions in some terms of what race and ethnicity mean. Mostly during the talk today, I'll refer to race, and I just want to make sure that we're all on the same page before we start, so you all know what it is that I'm referring to. So by some definitions, race refers to biological differences between groups assumed to have different biogeographical ancestries or genetic makeup. And while ethnicity incorporates something of that, it also goes a bit further, because ethnicity is a multidimensional construct reflecting, of course, biological factors, but it also includes geographical origins, historical influences, shared customs, beliefs, and traditions. And sometimes these populations may not actually have a common genetic origin. So for the most part today, I will speak to race, but it's important when we're thinking about the field to understand that both race and ethnicity can play a factor and a role in health disparities. The other point that I want to make just from the outset is in my laboratory, we study lung cancer. We'll talk a little bit about that later on. And when I study these populations, I refer to populations of European descent as European Americans and populations of African descent as African Americans. But you'll notice as I go through this talk, I'm interchanging these terms with the terms black and white. For the most part, with an asterisk, they mean the same thing in this context. And the reason I have interchanged them is because when I discuss literature, I have tried to remain faithful to what the authors of those publications have used and the terms that they have used. So I don't mean to confuse you in any particular way. And if any stage, if it is becoming confusing, just let me know. But some papers use the term black and white, and some use the term European American and African American. And so we have tried to stay faithful to that. Okay. One of the very first things that you'll observe if you read the literature is that or indeed in amongst our lives on a daily basis, is that the race differences in life expectancy in the United States, that there are quite significant differences. On average, if you are a Black man, you can expect to live 6.5 years shorter. And if you are a Black woman, you can expect to live 5 years shorter. So you might actually ask yourself, what are the key contributors to these disparities in terms of disease? Well, the first thing is cardiovascular disease. And there's a whole field of literature that addresses the role and the contribution of cardiovascular diseases to health disparities. But this is not something that we're going to primarily discuss today, even though it is a very important topic. The second biggest contributor to the differences in life expectancy between men and women in the United States is cancer. And that's what we're going to talk about today. So the NCI defines cancer health disparities as differences in the incidence, prevalence, mortality, and burden of cancer and related adverse health outcomes that exist among specific populations in the United States. And numerous studies have shown that African Americans have the highest death rates from all cancer sites combined, and especially from malignancies of the lung, colon and rectum, breast, prostate, and cervix. And this is compared to all other racial groups in the United States. So as public health issues go, there's an extremely important burden that needs to be both researched and addressed. So if you look quickly here, first of all, at the incidence rates of cancer, this is all sites combined in the United States. And this is looking at men, first of all. What you can see clearly is that African American men have a much higher incidence of all cancers combined compared to every other race. If you look at women, you see that white women have slightly higher rates of lung cancer, of all cancers, I should say, compared to all other groups. And perhaps one of the main driving factors for this is because breast cancer in women is actually higher in white people compared to Black women. And this is probably one of the reasons why overall you see a slightly less incidence of lung cancer. I study lung cancer, so forgive me if I say it intermittently throughout, but of breast cancer throughout all these groups. One of the other interesting things to note is that in general, even though African Americans are more likely to have and to be diagnosed with cancer, there's been an interesting trend in the literature where they have also noticed that for quite a few cancers, African Americans are also more likely to be diagnosed at a younger age. Now, on this graph here, you can see that we have gray bars and we also have black bars. And just to highlight that those that are black indicate those that are statistically significant. In previous years, studies have been done that have addressed this issue, and they found quite wide ranges and an earlier age of diagnosis for African Americans. This study, which was published by a group in DCEG just this year, looked at the problem in a slightly different way and controlled their analyses in a much stronger way than some of the others had done. And they still find that, in general, African Americans are diagnosed at a younger age. But the difference in diagnosis was somewhat smaller. Now, there are several cancers where these differences remain, and these are shown here at the bottom and include non-Hodgkin's lymphoma, anal cancer, soft tissue cancer, specifically in males, and Kaposi sarcoma. And those of you who are familiar with HIV-related cancers will know that quite a few of these cancers are actually related to HIV infection. And so most of the differences that are observed in age of diagnosis seem to be driven by HIV-related cancers. But there are still differences overall. Excuse me, I have a small cough today, so I apologize for that. So as I'd mentioned, there are 4 main cancers where, without question, the cancers are diagnosed at a younger age in Black men and women. So what could the potential causes of these early diagnoses be? Well, as I just mentioned, one of them could be an etiologic heterogeneity. So what do we mean by that? Well, perhaps the cause of the cancer is different across the groups. So there could be a different etiological agent in different populations, or it could cause cancer at different ages. Another possibility is that different subtypes could be caused by different cancers, and they could also contribute to disparities. Across different populations, there could also be differences in the timing or intensity of the exposure. For example, exposure to tobacco could occur at one population versus another. And if you remember on the graph previously that I showed you, lung cancer was one of those cancers which is detected or diagnosed earlier amongst African Americans. And in addition, the timing, the prevalence, and the frequency of an early cancer detection can vary. So for example, through screening, for example, if populations are more likely to get screened, their cancers might actually be detected at an earlier age. And so I'm going to leave this here for now, but I will come back to this point later in the talk or in the lecture today and talk a little bit about why the age at which cancer is diagnosed are important in combating some of the disparities in cancer. Okay, so switching then from incidence rates to mortality rates, and shown here you can see graphs for both men and women. And you can see again that for every single cancer type, that the mortality rates are higher for both Black men and Black women than every other group in the United States. As I mentioned on the previous slide, African Americans have the highest rates of cancer-specific mortality. And we know that the racial differences are not reducing over time. Now, in general, the survival from cancer, almost from every cancer site, is getting better. But those differences in outcomes are not getting smaller. And that's something that has to be addressed. For cancers like breast cancer, there's an indication that they may perhaps even be getting worse. And if you look at this graph here, you can see that they show 4 of the major lethal cancers, which are prostate cancer, breast cancer, lung cancer, and colorectal. And you can see for all of these combined that African American men and women have a much worse survival than Europeans. So what are the key determinants of disparities? This is a figure that was taken from a recent paper by James et al. And it's a little bit complicated in its organization, but I like it because it actually touches on each of the factors that contribute to the disparities. And most of these we're going to go through to different degrees in the subsequent slides. Okay, so if we could think about incidence for a moment, what are the main causes of disparities in incidence? Well, one possibility is geography, so location, the actual geographic location. Another possibility is perhaps genetic. Could it be due to differential susceptibility, perhaps? Another possibility is tobacco use. And of course, other possibilities include nutrition and physical activity, and of course, exposure to viruses such as hepatitis B and also HPV. When we think about disparities in mortality, what could the causes be? Well, some of them include a lack of early detection, a lack of timely and aggressive treatment. Access to care is a huge problem in this area, but also towards the end, we'll also discuss the potential role for genetics and biology. Okay, so going back then to disparities in incidence and looking at geography. So first of all, this is a graph of just showing the incidence of all cancers combined across the United States. And so the first thing that you can see is that even if you combine all cancers together and irrespective of race, the incidence of lung cancer significantly varies by states. So some of the highest rates are in Kentucky, Rhode Island, and Delaware, whereas some of the lowest rates of cancer are in New Mexico, Arizona, and Wyoming. So even just at that level, you can see there are geographical differences in the incidence of cancer. If you look at lung cancer specifically, so not just every cancer, but lung itself, again, you can see there are states where there are very high rates of lung cancer and others where it's actually quite low. And if you break this down by race, again, you can see that while some states have similar incidences, there are others where the differences are quite different. And this is just one here. It's quite low, and you can see in African Americans it's quite high. Now, while these are observations that we can see, we do not yet really know what the causes of these geographical differences are. Some people have speculated that it could be due to residential migration, it could be related to racism, advertising, cultural influences, community structure, and also social stress. It has been shown that a low socioeconomic status neighborhood can confer an additional incidence or mortality risk beyond an individual's SES. And so why would that be? Well, in some cases, it could be because these neighborhoods that have a low SES could actually have an unequal burden of pollution. We know, for example, that areas that have the highest percentage of African Americans living in them also have the highest exposure to cancer-associated pollutants. And in some cases, there's also increased exposure to secondhand smoke, which we know is a risk factor for lung cancer, and indeed perhaps as well pancreatic cancer. And so it raises the question about whether or not a deleterious neighborhood effect early in one's life could affect health outcomes through physiological adaptations to the environment. And this is somewhat similar to the Barker hypothesis of the development origins of adult diseases, including things like heart disease and diabetes. Now, the mechanism of adaptation is likely to include an epigenetic modification of gene expression. And again, this is something that we'll revert to again later on when we talk about biology. So what about genetic susceptibility? Is there a role for genetics and susceptibility for the increased incidence of cancer in different populations? Well, some of the best evidence for this comes from prostate cancer. Many of you will already be aware of the important link that there is between the AQ24 region with prostate cancer. Now, admixture, and indeed other cancers, but certainly prostate cancer. Now, an admixture analysis looking specifically at AQ24 identified it as an area of increased risk. But importantly, the risk alleles were more common amongst African American men compared to European American men. And there's also an excess of African ancestry at AQ24. And so what papers have now suggested is that up to 80% or 50% of the disparities between African Americans and European Americans in terms of prostate cancer incidence can actually be explained by this specific locus. Now, recent work has identified another location at 17q21. Again, this is an area that's associated with prostate cancer risk, and the risk alleles also seem to be more common in populations of African descent. And this particular locus, it is believed, accounts for another 10% of the disparities in incidence between these two populations. So collectively, about 60% of prostate cancer incidence disparities could be explained by genetics. Now, in terms of breast cancer, there are racial differences in the prevalence of a 5p15 location. The risk alleles at this locus are twice as common in populations of African descent compared to European Americans. And African American women we know are more likely to be diagnosed with ER-negative breast cancer. And this is all related to the TERT locus. The evidence for a genetic contribution to disparities in breast cancer incidence are not as strong as they are for prostate. But there is some evidence to suggest that genetics can actually play a role. And if we also look at genetic variation in a recombination gene, it's found that it drives hotspots of recombination, specifically in African Americans. So recombination, as we know, is a frequent event in cancer, and there is risk alleles in this PRDM9 gene, which are enriched in African American populations. Now, whether or not this is associated with disparities in lung cancer or indeed other cancers still remains to be studied. But collectively, this literature suggests that while genetics do not explain the entire differences in disparities in incidence, they certainly seem to be playing a contributory role. So what about tobacco use? Well, let's take a moment and take a look at the lung cancer incidence in men and women. And I choose lung cancer here as an example because, of course, smoking is the main etiological factor that's associated with lung cancer incidence. Now, if you look across these different populations, what you see is that there is a very striking difference in the incidence of lung cancer across these groups in both men and women. African Americans and Native Hawaiians have the highest incidence, while Latinos seem to have the lowest. And this is a similar trend in both men and women. Now, if differences in tobacco use were the main drivers of this disparity, then when you look at tobacco use among these populations, you might expect to see quite a similar pattern, especially given that tobacco use is the major etiological cause of over 90% of lung cancers. But when you look at smoking prevalence, you see a very interesting trend. And here I'm showing high-intensity smoking prevalence. And you can see that 5.8% of African Americans are classified as heavy smokers, compared to 19.2% of European Americans. And so what this suggests is that while we're not excluding the fact that tobacco might play a role, at least initially, it does not look like it is a major driver of the disparity. We also know that African Americans tend to initiate smoking later in life. Like we just showed you, they smoke fewer cigarettes. As adults, the prevalence of smoking seems to be the same, but of course the intensity of smoking seems to be less. Individuals and researchers have looked at never smokers. And if you look at never smokers, you can also see a disparity in incidence. And if you look at patterns of smoking, it's known that African Americans are more likely to use menthol cigarettes. And studies have also looked at whether or not actually smoking a menthol cigarette in itself can carry a higher burden of disease. And the literature is quite conclusive to say, at least to date, to show that smoking menthol cigarettes is not associated with an increased risk of lung cancer relative to non-mentholated cigarettes. Now, a recent study that was conducted by Chris Hyman and colleagues did a very nice study where, again, they looked across each of the different ethnic groups, excuse me, looking at those who smoke less than 10 cigarettes a day and those who are high-dose smokers, those who smoked more than 30. And they looked at this in both men and women. And what you can see in the graphs is that, again, without question, similar to what we saw before, African-American men and women have a higher incidence of lung cancer compared to every other group. When you look at higher doses of smoking, you can see that this difference is attenuated. So what does this suggest? Well, the data from this paper suggests that for reasons that we don't yet understand, it is possible that African Americans are more susceptible to lower doses of tobacco. We do not know the reasons for this, and it has never been empirically tested in the laboratory. But this was a very well-powered study, and the data, while disparities may still exist at these higher doses of smoking, there certainly seems to be an increased susceptibility at this lower dose of tobacco. And again, this is something that we will discuss later, as in what are the consequences of this. So as we mentioned, we went through a few of the different disparities in incidence and possible reasons for it. They include geography, genetic susceptibility, tobacco use, and of course, a lot of things that we just don't know yet. So we move on to potential causes for the disparities in cancer mortality. The first thing that we think of course, is a lack of early detection. So for example, if you look across at these 5 different cancer types, you can see that unparalleled for all of these different cancer types, you can see that African Americans are less likely to be diagnosed with an early stage disease. You can see that here for colorectal, esophageal, lung, and also melanoma. If you see here the example for kidney and liver, there doesn't seem to be a difference. But the reason that these observations are so important is because we know also from Jamal's studies that being diagnosed with cancer at an earlier stage leads to much better prognosis. So just by detecting cancer at an early stage, you are more likely to survive. And this is something that we have known for a long time. So could the disparities in incidence be due to a lack of early detection? Well, early detection is of course inherently linked to screening. So is access to screening prohibiting the identification of these cancers at an earlier stage when they're more likely to be treated and cured effectively? Well, there could be an issue in access to screening for some cancers. But we do know that breast cancer mammography use is similar amongst different populations in a setting of equal access to care. We do know that regardless of equal access to care, colorectal cancer screening and uptake of screening is lower amongst African Americans. And indeed for other cancers such as HPV, there also seems to be a lower uptake in screening in these populations. But it's important to mention that differences in survival exist for cancers even where there is no validated screening program. So this would include cancers like lung and esophagus. So access to screening, while it may contribute to cancers like breast and perhaps prostate with PSA and colorectal cancer, it does not account for the differences in lack of early detection for cancers such as lung and esophageal, because there isn't mechanisms of screening in the population for those. Although for lung, I should say that there is a screening mechanism for that this year using low-dose CT. Talk about that later. Okay, so could the differences in cancer mortality and disparities in cancer mortality be related to access to care? This was a nice study that was published about 2 years ago. And what it shows is that if you take 3 different groups of populations, and this is for several different cancers, those up here in green are insured people. The blue is Medicare patients, and then the dotted red line are patients who are uninsured. And you can see for almost every single cancer that's shown here, those patients that are, those patients that have insurance have a much better outcome. So that suggests that access to care is an important factor and contributing factor for the differences in disparities. So there have been several studies that have been done in settings of equal access to care. So what kind of settings would this be? Well, this includes VA hospitals, the DoD health system. These are all settings where regardless of your age or gender or race, you have an equal access to care. And this is just one example from lung cancer, which was published, but there are more examples for lung cancer in the field, where if you take patients where when there's a non-equal access to care, there's a disparity of outcome. If you take those patients and look at them in an equal access to care setting, you can see that regardless of histological type, there's absolutely no disparity in outcome. And so what this suggests is that access to care is a very important contributor to the disparities in mortality across different populations. This is another example here for renal cell carcinoma. Again, in settings where there isn't equal access to care, the mortality from renal cell carcinoma is higher in populations. But if you look at an equal access to care setting, there's a suggestion that they actually do better even than worse. And similar trends have been seen for pancreatic cancer. Multiple myeloma, again, is another example. This is a cancer where there is a significant difference in incidence. You can see that African Americans are more likely to be diagnosed early and more often than European Americans. But if you look at an equal access to care setting, any disparities that there were in outcomes tend to go away. And in fact, in some cases, they actually do better. So again, these are all studies suggesting that access to care is a very important factor in looking at the determinants of disparities in cancer outcomes. So in addition to having access to care, an important factor is uptake of care. And we're going to discuss some literature on that. So even amongst those in Medicare, which again is considered in some ways to be an equal access to care system, there are differences in uptake of care when you compare European Americans and African Americans. So here's one example from lung cancer. And if you look at, surgery, you can see that European Americans are almost twice as likely to have surgery than African Americans. And the same is a similar trend is seen for chemotherapy. If you look at African American renal cell carcinoma patients, they're also less likely to receive surgical treatment, so-called nephrectomy, and also more likely to die of competing causes compared to European Americans. So it's not always about access to care. Another important problem is related to uptake of care. In this setting of equal access to care, again, this is an example of colon cancer. African Americans were less likely to receive surgery and chemotherapy compared to European Americans. And again, another example, this is a regular medical settings. This is not equal access to care. Studies consistently show that racial disparities in specialist consultation, so this would be a medical oncologist or a surgical consultant, as well as a subsequent multimodality treatment, disparities in treatments for metastatic colorectal cancer exist. And these are all really important things because these are all factors that contribute to outcomes. And as the literature shows us consistently that there are disparities. So what are some of the reasons or potential reasons for disparities in cancer mortality related to the access and uptake of care? Some studies have been done in this regard to try and address this. And some of the potential factors that influence the uptake of care include, in some cases, personal beliefs, can include fear, specific cultures. This gets back to ethnicity. It could be the patient-doctor relationship or the provider relationship. There could be patient bias, provider bias. Communication can be very important. And indeed, in some cases, certain comorbid conditions can increase or decrease the likelihood that a patient will go for surgery or go for chemotherapy. Another important potential contributor to disparities is smoking cessation. So we talked about tobacco a little bit earlier when we were talking about reasons for disparities in cancer incidence. But it has been known for a while now and conclusively shown again in this just recent paper from CEVP, that patients who continue to smoke after a cancer diagnosis have a significantly worse outcome than those who actually quit smoking. And this is the scale at the bottom here is a little bit messed up, so I apologize for that. But this second example here is for lung cancer, and you can see that those who continue to smoke heavily have an 8-fold or 9-fold increased relative risk of death, which is really quite high. And that is why smoking cessation messages really should be a very important part of your cancer treatment. And there is a push, well, there has always been, but there's also an additional push to make sure that that message gets across to patients. But in addition, you can see this not just lung, it's for colon, pancreatic, bladder, liver, and prostate cancer. You can see that for all of those patients, there's an increased risk of death amongst those patients who continue to smoke. And so why is that important in terms of disparities? Well, we know that racial disparities in continued smoking exist, and especially amongst African Americans. So we know that so what are the possible reasons for this? Well, some socioeconomic vulnerabilities, including poverty, stress, and secondhand smoke exposure, can all contribute to an increased likelihood to continue smoking. And we also know that although the majority of African American smokers express the desire to quit smoking, they are less likely to receive and use evidence-based treatments. So what are the evidence-based treatments? They include screening for tobacco use and advice for quitting, smoking cessation pharmacotherapy, and also counseling. In addition, we also know that African Americans are less likely to enroll in smoking cessation trials. And it's also possible that menthol cigarettes, which we mentioned earlier, it might be harder to quit them, which in itself could also contribute to these poor outcomes. Excuse me. So we've discussed several factors that seem to contribute quite largely to disparities in outcome among African Americans. It includes access to screening, access to care, utility of this care, and of course, smoking. But there seem to be some cancers where even in an equal access to care setting, disparities in survival exist. And so I'm going to take you through a few of those examples. The first of these, and the most prevalent and the most reproduced in the literature, is an example of breast cancer. So studies have consistently shown that even in an equal access to care setting, African American women have a much worse outcome than European American women. And this has been shown over in many different studies. And this is just another example showing from a clinical trial setting where, again, the patients have equal access to care. And in this study, what you see is that for several cancers, including premenopausal breast cancer, postmenopausal breast cancer, advanced non-Hodgkin's lymphoma, advanced ovarian cancer, and indeed for advanced prostate cancer, persistent disparities in outcomes exist. And so this leads us to ask the question, could biology be a contributing factor? Now, I mentioned prostate cancer just there a moment ago, but it is important that I also mention that the literature regarding disparities in prostate cancer is a little bit more heterogeneous than it is for breast cancer. There are some studies that show that if you have an equal access to care setting, African Americans and European Americans have a similar outcome. There's also many studies showing that they have dissimilar outcomes, where African Americans have a poorer survival. And it seems to be that perhaps some of these disparities in the literature could actually be explained by the fact that some of the prostate cancers that are diagnosed are lethal and some are indolent. And we know, for example, that African American, there's a faster growth rate and an earlier transformation in European versus in African American compared to European American tumors. And it's also been observed that clinically localized cancers from African Americans more closely remember metastatic cancers from white men. So it seems that the actual cancers that are diagnosed might actually be more aggressive than in African Americans than they are in European Americans. So it's important that while data suggests that access to care is a factor in many different cancer disparities, and we went through a few examples earlier for multiple myeloma, for lung cancer, for renal cell carcinoma, other factors, specifically for breast cancer and prostate cancer, suggest that tumor biology and genetics may also play an important role. So when we refer to differences in biology and genetics, what kind of things could we be talking about? Well, we include genetics themselves, of course. We talked about susceptibility loci earlier in the talk. We're also thinking about somatic mutations, the molecular subtype, gene expression, methylation profiles, indeed inflammation, and also cell biology. And so I'm going to go through a few examples of these in relation to breast cancer and prostate cancer. So this locus is one that we mentioned earlier, and this is the AQ24 locus. And even though we've discovered that it's associated with a higher incidence of prostate cancer in African Americans, we also know that that same locus is associated with a higher grade and more aggressive prostate cancers. And this is an example shown here for that region. And you can see that there's this linear increase in the aggressiveness of the prostate cancer as it's diagnosed for individuals who don't carry the risk allele, for those who have one copy and for those who have two copies. And you can see these patients are also more likely to be diagnosed actually with the lymph node metastasis. So there is a genetic contribution to disease aggressiveness in African American men that seems to be driven by this AQ24 locus. There's also a duplication event at 14q32.33, which is being discovered, and this is in the IGHG3 gene. And this particular amplification was discovered, I should say, in familial studies, suggesting that it could also lead to an inherited predisposition. And it's possible, but hasn't yet been fully proven, that it contributes to higher prevalence and mortality of prostate cancer in African American men. Now, aside from these particular familial and inherited studies, there's also evidence to suggest that if you just look at the tumors themselves and compare them between African Americans and European Americans, the copy number at different loci across the genome is very different between the two populations. So here's one example up here showing African Americans. As you can see, there are some loci. So the yellow loci are those that are gained, and the blues are those that are lost. And you can see, looking at two different populations, you can see that there are several differences, suggesting that at genetic level, there is a contribution in the difference of the biology of those tumors. Looking a little bit at somatic mutations, so we know that there's a very important role for driver mutations, not just in the biology of a tumor, but also in the outcome. So in lung cancer, or in prostate cancer, excuse me, some of the main somatic changes include ERG, so Temporous ERG fusion gene, and also PTEN. And studies have been comparing the different somatic profiles between European Americans and African Americans. And while there are some differences, what they find is that for some of these key somatic driver mutations, there are also differences in them. And so while there's a higher frequency of the Temporous ERG fusion gene in European Americans, it's much lower in African Americans and even lower again in Asian populations. And while PTEN loss is common in populations of European descent, it seems to be relatively uncommon in populations of Asian and African Americans. So again, what this goes to show is that from a geographic population perspective, there is global heterogeneity in the acquired mutations in prostate tumors. There are also, when we think about the molecular subtypes, so breast cancer, as many of you will know, is one of those cancers where there is specific subtypes at a molecular level that have been ascertained. And we've known for quite a while now, quite a few years, that there are population differences in the prevalence of these specific subtypes. So one example would be that there are both race and ethnic differences in the prevalence of the basal-like or triple negative-like breast tumors. So if you look here on this graph, what you can see is that the basal-like phenotype is found in 39% of African American patients, but only 16% of premenopausal. So how could this contribute to poor outcomes? Well, we know, for example, and many of you will know, that this particular subtype is an extremely aggressive form of breast cancer, for which there is very few therapeutic options. So that could be one of the reasons why it drives the worst outcomes. And we also know that in populations who live in Africa and breast cancer patients from Africa, they are also even more likely to have this type of breast cancer. Again, suggesting that there is some kind of genetic contribution to this particular phenotype in amongst breast cancer patients, which to date hasn't really been ascertained. One important caveat to note, and a little bit to counter what I just said, but not to confuse you, is that the association between, or the difference in survival between African American and European American breast cancer patients is certainly seen across several different cancer types. So even though I've mentioned that this triple negative breast cancer is more common in populations of African descent, that is not to say that it is the only or the sole or the key driver of those disparities. That's also something that's important to mention, but it is likely to be a contributor. Okay, so what about the cell biology itself? So some of the studies that we do in our lab on lung cancer look at this. And there's been several studies that have been done by Stefan Alms in recent years as well, where looking at breast cancer and a prostate cancer, he's taken apart and tried to dissect through the cell biology of those tumors. So when we do this across every cancer type, we seem to see a certain set of genes that seem to be race specific. And we see this in lung, in breast, in prostate, in colorectal. But the thing is that these specific genes, they're not typical cancer-related genes. So while there are racial differences in gene expression, they don't seem to be specific cancer genes, or at least what we have come to know as cancer genes. So when you take a step back and look at what the pathways are that are represented by these genes, in prostate cancer, we can see that the majority of these genes that are different by race in prostate tumors seem to be related to the immune system. This is an example here of some of the genes that seem to be upregulated in African American tumors compared to European American tumors. And many of these genes are related to viral infection response genes and actually an interferon signature. In similar work in breast cancer, it's been found that the interferon signature predicts survival and poor outcomes and is also associated perhaps to resistance to chemotherapy, again suggesting that the biology of the tumor itself could actually be a driver of the disparities. As I've mentioned in breast cancer, again, a similar thing has been found. While the same gene signature was not observed, there was definitely an increase in macrophage infiltration, microvessel density, and interferon signature was also observed, suggesting that these differences in cell biology are important drivers of the differences in outcome. And it's important to know that information because once you identify a difference that could be related to outcome, it's then possible to either target or to leverage that difference to improve outcomes. So we also know that even though differences in methylation are not as prominent as differences that we see in gene expression, there are methylation differences in tumors. This here is an example from breast cancer, and you can see that there's this middle section here, which is much, much different to the other two subgroups here on the left and right. And you can see that most of the European Americans cluster here. So globally, though they're not extremely prominent, there are changes in methylation between the two populations. And to go back to something that we mentioned earlier with regards to socioeconomic status and the neighborhood effect, a study was done a couple of years ago where they looked at population differences in gene-specific DNA methylation at birth. And they saw, this was looking at about 100 European American, African American newborns. And they did see differences in the different populations. But what was interesting is that the differences between the two populations clustered in cancer-related genes. This is an observation. We don't know if it's actually causal or not, but it's certainly something that that some people are following up on. I'd mentioned inflammation has been, it seems to be important in terms of both prostate cancer and breast cancer disparities. And it's interesting because there's quite a long literature that describes difference in inflammation between African Americans, European Americans, even just in general outside of a cancer context. We know, for example, that there are some autoimmune and infectious diseases which are more common, including lupus and TB. We also know that there's increased circulation levels of IL-6 and indeed other cytokines from studies that we have done. There's differential allele frequency. So again, this could be driven by a genetic susceptibility or a genetic reason for these higher circulating levels. And as I've mentioned, we also know that cytokine profiles from in the serum are also different. And it seems that they are also associated with poor outcomes. And this is in the context of lung cancer. Interestingly, inflammation in non-cancerous prostate biopsies has been found to be more prevalent amongst African Americans compared to European Americans, again suggesting a heightened role for inflammation. And it's also known that African Americans are more likely to have some comorbidities such as COPD, which of course is chronic obstructive pulmonary disease. So the idea that inflammation could be a contributing factor from a cell biology perspective is backed up by quite a strong literature that also supports the role for inflammation in differences between the biology of these two populations. So if there are different cell biology signatures, what are the potential drivers of it? Well, one possibility is viral infections. We talked as well about the example of germline SNPs. So for example, increased IL-6 seems to be driven by a particular haplotype in African Americans, which gives rise to higher circulating levels. There's also a gene called MBL2. It's an innate immunity gene, also associated with colon cancer, actually only in African Americans. And through studies that we have done, we have found that that particular genotype is associated with increased circulating levels of this particular gene. Now, while this is good from an inflammatory perspective, it also becomes a risk factor for cancer. It could also be due to differential genetic mutations that are acquired in the tumor. Now, why would there be differential acquired genetic mutations? It could be because of different etiologies. So, for example, we know that smoking is highly associated with p53 mutations. We also know that aflatoxin, if you have a p53 or 249S mutation in your liver cancer, you can be very sure that that liver cancer is associated with aflatoxin exposure. So there can be this very tight link between exposures and somatic mutations, which can provide clues not only to the etiological source of the tumor, but also perhaps to differences in those etiologies. And of course, it could also be due to toxins, air pollution, carcinogens, so many different things. And we know that each of these things can all reflect the tumor biology, but what we don't know yet is if and how each of these exposures contribute to the biological determinants of cancer health disparities. And that's one of the important questions that we are trying to address. So just to finish up, I wanted to go through a few additional perspectives. One of the things that is a good, one of the positive things in the advances in cancer research in the last number of years is that there are many more cancer survivors. And of course, this is something that we're trying, this is a good thing. But the problem is that cancer survivors are also at an increased risk of cancer. And some studies have now started to be conducted to compare the incidence and the prevalence of these second cancers across different populations. And so perhaps it shouldn't be surprising to note that just while there are differences in the incidence of primary cancers in different populations, we also now see that there are differences in the prevalence of second cancers. And this is important because from a prevention perspective, from a treatment perspective, from an access to care perspective, these are all very important observations that should be kept in mind from a medical care perspective. In addition, one of the other factors that has been more and more prominent in health disparity research in the last number of years, and that really has been driven by advances in technology, is something called ancestry informative markers. So this, for example, shown here is a frequency histogram, which shows the percentage of African ancestry in a particular population in Cleveland. So we know that African and European ancestry vary greatly in self-identified African American people. Now, most of the studies that we do, if we start a study and I'm administering a questionnaire, I'll ask you, what is your race? And so it's a self-identified race. Some people will say I'm white, some people will say I'm black, some people will say I'm Hispanic, some people will say I'm Native American, and that's okay. But there's an increased granularity that we lose just by asking that question alone. And this graph actually illustrates some of the point of what I mean. So if you ask somebody who what their race is, and they say, I am white. If you actually do a genetic test on their DNA and say, well, okay, how much of their DNA has a European ancestry? In most cases, you can see that it's pretty homogeneous. So most people who self-identify as white have a fairly strong European ancestry. There's only very small, 3% of African ancestry in their DNA. But there's an extremely wide range. If you ask an African American or a black person the same question, you see there's an extremely wide range, a percentage of African ancestry in their DNA. Now, for a lot of cases, this is not important. But for questions, and I'll give you an example in a moment, when we are looking at genetic susceptibility to disease and factors related to genetics, it does become very important to address these types of questions. And in addition, this is just, yes. Yes. Yeah. And in fact, only you mentioned something that I've forgotten to mention, which is only 3% of individuals who identify as black had greater than 80% African ancestry. So there is a huge variation at a genetic and quantitative level in the amount of African ancestry. And for things like access to care, that may not necessarily be particularly important, but when we are looking at the biology of tumors and genetics, it becomes quite important. And I'll give you another example of that in a moment, but very well spotted. So this is just another example looking at various African American communities across the United States and the percentage of European contribution to those. And it varies tenfold. If you take this population over here, who are self-identified as African American, 35% of their DNA is actually European American. In some cases, it's lower. There's an example over here, which is at 3.5%. But the point of the map is just to give you another example of the range and the difference in the percentage of African and European ancestry in these populations. So moving a little bit into perspective of screening, but also from importance from an ancestry informative marker perspective. So many of you will have heard about PSA, which is prostate-specific antigen. And it is a marker that is used to try and predict risk of prostate cancer development. We know that PSA levels, several studies have shown that it can vary by both age and ethnicity. So if you take a population of people, and this is work that was led by Rick Kittles, who has pioneered a lot of the ancestry informative marker work. If you take this population and you say, based on self-reported race, you measure PSA, well, for the cutoff is normally set at 4.0. If you ask the European American population who have a PSA value of 4, you can be about 38% positive that within 3 years, those people are going to get cancer, prostate cancer. If you look at an African American population, again, and take the same cutoff, in this population, you are 62%. That population is 62% more likely to get, not more likely, excuse me, let me rephrase that. For African Americans who have a PSA level of 4, there is a 62% likelihood that within 3 years, that population will develop prostate cancer. So the same marker in 2 different races by self-report gives different information. And this is important for screening guidelines, because if you are to take somebody who comes into the clinic, or a doctor is going to take somebody, and based on just look at everybody in the same way, you're not going to get that level of important personalized care that is needed. Now, if we take this a step further and introduce ancestry informative markers, how does that help us in giving a more accurate diagnosis? Because remember, or an accurate public health message. Because remember, I told you that within those African American populations, there are some people who are primarily European and some people who are even have a higher percentage of African ancestry. So from a medical perspective, how is that dealt with? Well, in this example, if you just measure the percentage of African ancestry in each of those patients and divide into 3 groups, so low, medium, and high, what you see is that as African ancestry increases, the likelihood of getting the right diagnosis also increases. So by introducing this type of marker into your analysis, you get a greater refinement and a greater granularity in the prediction of the diagnosis, and that can be very important. As another example, I know this, I'm talking about screening here, but from the same perspective, there's an increased proportion of Native American ancestry that's associated with an increased risk of childhood acute lymphoblastic leukemia. So this also has screening implications, because again, it's also related to treatment, because children with more than 10% Native American ancestry need an additional round of chemotherapy in order to respond. So just by looking at someone, can you really be accurate and say, oh, I think it's 10%, I think it's 20%? It's very difficult to do that. And so that is why introducing something like ancestry informative markers really does provide a greater granularity to studying race. And so in our studies of lung cancer, we're just in the process now of completing an ancestry informative marker analysis of every single one of our samples. And just to try and, not to belabor the point too much, but to give you an additional example about how it's so important. So in lung cancer, for example, when we're studying smoking, which we always do because it's so important, we will ask you when you come in if you're an ever smoker, a former smoker, or a current smoker. And that's very important information. And if you tell me you're a current smoker, then that is correct information. It's not that it's incorrect. But there's a lot of granularity there that we don't have. So for example, I could be a current smoker and have smoked 30 pack years over my lifetime. So that would be a pack a day for 30 years. Now, you could be a former smoker and consider not really to be as high risk, but also have smoked 30 pack years. You just gave up a year ago or 2 years ago. So if you don't also collect information on pack years and the amount of cigarettes that people smoke, you actually lose a lot of very important information. And so that is why I'm glad to see there is a move in the field as a whole to incorporate more of this type of research into the questions that we ask. I wanted to mention one other important point with regards to screening in relation to lung cancer. And the main reason for this relates to something that we talked about earlier. So this year, a method called low-dose CT screening was approved as a screening tool to reduce the mortality of lung cancer. It's been shown to reduce mortality by about 20%. This is a huge potential public health advance, and it's very, very has a potential to save a lot of lives from lung cancer. It's only at the moment approved for high-risk smokers, so high-risk individuals. And so one of the criteria is that you have to have smoked more than 30 pack years, okay? Which is, again, is a high-risk smoker. They smoked 1 pack a day for 30 years of their lives. So this is a lot of, and these are the highest risk people. But you remember earlier when I talked to you about that study by Hyman and colleagues, we showed that most African Americans, when they're diagnosed with lung cancer, they don't smoke 30 pack years a day. They don't have a 30-year pack year smoking history. They have a 10 pack year smoking history. And so what does that mean in terms of screening? Well, if you were to look at it, there's a potential that you could miss 40% of lung cancers in African Americans if you use these screening guidelines, compared to 25% in European Americans. So why is this important? Well, right now I showed you that in equal access to care setting, there are no disparities in lung cancer outcomes, and that is a good thing. But if we don't pay attention to factors like this and in new screening guidelines and don't try and tailor them based on the biology and the epidemiology that we see, we could actually have an unintended consequence of actually widening the disparities. So that's just something to keep in mind, and not just for lung cancer, but also for other types of cancer as well. The other thing I wanted to come back to, as we mentioned earlier, about this observation that for some cancers, there is an earlier diagnosis, I should say, among certain populations. This is again important from a screening perspective. And the reason is that when screening guidelines are given, they define an age range or a risk factor exposure range. And if age is one of those exposures for a particular population, it raises the question, do these guidelines need to be population specific? Okay. One other thing just to kind of mention as we move forward, many of you will be aware about the tremendous advances that there have been in biological targeted therapies, and they really have increased the survival for a lot of patients. But I mentioned to you earlier that we are aware of biological differences between the tumors. So even at the moment, for cancers like lung, where it doesn't seem to contribute to differences in outcome, it does for breast and prostate cancer. There could be another unintended consequence here, because there's some studies that are beginning to suggest, for example, hepatocellular carcinoma and multiple myeloma, where there have been some targeted therapies and specific therapies, that because there are differences in the biology, it's highly expected that there will be differences in the responses of those particular tumors. So again, many of these studies are more likely to be done in populations of European descent, simply because 72% of the population is of European descent. But it's very important within these studies to also consider, will this drug be effective in populations of other races and ethnic groups, and to ask the question, based on the cell biology, do we expect to see similar responses? And if we don't, to consider that in the therapeutic and the clinical setting, and also importantly in the research setting. So just to sort of sum up before I'm happy to take any questions, we know that there are several drivers for differences and disparities. These include geography, genetics, and also tobacco. This is by means not an exhaustive list. It is not possible to go through all of them. And also it's important to say that there are a lot of factors that we don't know, and that's why research in this area is actually so important. In relation to disparities in mortality, we look at things like lack of early detection, access to care, lack of timely and aggressive treatment. Genetics, I will also discuss, seem to play a role, as does biology. I hope you've got the message that the determinants of cancer health disparities, both in terms of incidence and mortality, it's a multidisciplinary problem which requires a multidisciplinary approach. And that is why doing this kind of research at the NIH is such a fortunate place to do this kind of research, because we have access to experts in all these different areas. It requires a lens that looks at prevention, early detection, diagnosis, treatment, and mortality. And there is no one factor which will explain the disparities in all cancers, and there's going to be no one solution that will be able to address them. And that's why for this particular field, it's important to work and to look at these things through a multidisciplinary approach. In our study, or in our lab, I should say, we use the Maryland case control study to achieve this. We examine the contribution of environmental and inherited factors to the excess cancer burden amongst African Americans. I focus on lung cancer, primarily as I've mentioned, and Stefan Ams focuses mainly on breast and prostate cancer. So we're always available if anybody has an interest or questions or follow up after this if anybody is interested. So with that, I'd just like to thank my own lab and also those involved with the NCI Maryland case control study. And of course, happy to take any questions that you might have. Yes. Yes. So the question was, do the main risk loci that we're aware of, do they, for breast and prostate cancer, do they mainly come from GWAS? And the answer, I should say, to your question is that they definitely do. They were initially, of course, discovered in populations of European descent, but then because breast and prostate cancer are such prevalent diseases, it was possible to build enough power to look at that within African Americans, and indeed of populations of African descent. There have. So many of you will be familiar with the cancer TCGA, so the Cancer Genome Atlas Project. And within those, there are some samples that are from African Americans. But one of the biggest problems there is power. So that is why studies like what I am doing in lung and what Stefan is doing in breast, we're doing sequencing on those ourselves, because we have using this case control study, because it's set in the Baltimore region, we have an overrepresentation of African Americans. And so because of that, we're able to get enough power to ask those important questions, because there isn't enough data, at least yet, within the TCGA resource. Okay, great. Thank you very much for your attention.